very much. We will now take about 30 minutes of questions for the panelists, and then we're going to have a 10-minute break. If anybody who has a question would come up to the microphones in the middle, that would be great.
This is for Dr. Bliss. Doctor, I appreciated your presentation, and I'd like to ask you, if I were talking to my primary care physician and his associate and their PA, and there are a couple of people, and they're saying, you know, we're seeing 25, 30 patients a day, and this sounds like a great model. How can we transfer? How can we change over to your system?
Thank you for the question. So the question is, how would a typical insurance-based practice convert over to a direct practice? Am I correct? We've actually done this with a few physicians' practices in Seattle now. We're on our third. We call them conversions, practice conversions. Basically, it requires a couple of things. One is educating that person's patient population about what we do and how to make this work with the insurance they have, or if they don't have insurance. And we've learned a lot about how to do that. And so we educate the folks about how their current insurance would work with this, how they might want to change their insurance plan, say to a consumer-directed plan and what's deductible, combined with QnA. So there's education of the folks in the original practice. And the other part is you necessarily have to shrink the practice down, because typically these doctors have anywhere from 2,500 to 3,500 patients if they're full-time. So there's a shrinkage of that practice that has to happen, and what we've seen so far is it sort of happens by natural self-selection right now. Now, if all of those people wanted to come over, we might have an issue, although we have capacity with new docs we've hired who don't have patients with them, or doctors who are new to our practice. So there's an education process and a process of, we consider, right-sizing their practice, and then redistributing patients to other practices. Does that answer your question?
Do they have to opt out of Medicare then, as practitioners, to do this?
The practitioners in our practice have to opt out of Medicare, and it's every 2 years. So I just signed mine again, because we've been open for 2 years, and it just says that I will not bill Medicare for my services. And then the patients on Medicare who come to our practice have to sign an opt-out agreement with me, their provider, but they're not opting out for Medicare elsewhere in the system.
For the lay people in the audience, I've had some Medicare patients who have, for whatever reason, the doctor retired and is trying to find a new doctor and can't get in. A Medicare patient cannot pay cash to any doctor that accepts Medicare. So I can't see a patient and not bill Medicare if I've signed up with Medicare. And so there's some practices that just say they're close to Medicare, they're not going to take Medicare patients, but they keep their Medicare patients they're currently having. And they can't even add a patient on who say, yo, don't bill Medicare for me, bill mine. You know, I'll just pay you cash for what the service is. It's an interesting situation.
It's very perverse, I feel, and it filters throughout the system. We have a situation where we send electronically our x-rays to a radiology group to do an overread for us to verify that we've read the film correctly. If that patient is a Medicare patient, the radiology, they charge us about $20 to do that, and we pass that on to our patients. It's simple for us to charge the patient up front and say, we need to have this overread, it's $20. Well, the radiology group contacted us and said, any of these patients who are on Medicare, we have to bill Medicare for them or else it's fraud. So again, talking about that administrative overhead, now that radiology group, it costs us as well, because now we have to print up their Medicare card, the image we have on file, put it with the radiology read request, fax it over to the radiology group. They then have to submit a claim to Medicare for $20 to overread an x-ray. It gets kind of ridiculous.
Sorry. Next question in the back, Mike. Oh, you're in the back.
This is a question for Dr. Spencer. I became a group health member in April and was in the allergist's office at Capitol Hill, and as I was walking back to the exam room area, I passed a big sticky note that had AM huddle on the wall, and I realized that the Factoria medical home practice techniques had been imported somewhat to the specialty side of the practice, and I wondered if you could tell us a little bit about what components have been adopted by the specialty physicians in group health?
Well, thank you for your question. The question is basically what has transferred from the medical home model in a primary clinic to maybe other specialty divisions within group health. There are several features. Basically, the perception of the medical home probably is with primary care, but the features are certainly team building and a real discussion of the patient's care. So within specialty, I know some of the techniques of huddles, which are basically old hat. I think a lot of practices use them, but this is the first time that people have really embraced it. And this allows teams elsewhere to look at processes that are patient-centric. So I think that movement has translated to other areas.
I'm just wondering how the insurance model disrupts or encourages either the home patient model or acute alliance. In other words, if the doctor had 1,800 or 800 patients, is there a disruptive event that occurs if some of the patients change health plans and maybe the next health plan is not accommodating to the way you're doing it? Or with group health, if the employer went from group health to some other carrier, and how could they maintain that? They just not have that home patient model, maybe another carrier. You see what I'm saying?
Do we have both Dr. Spencer and Dr. Bliss take that?
Go ahead, free. So I think the question is, how would a patient who might be involved in a medical home, what would happen if their insurance changes? There are actually a lot of practices, primary care practices, that are trying to do this model. And I'm not sure quite how one would find out about these practices, but I'm aware of a practice, for example, in Whatcom County, and I've asked my friend, well, how do you recover from insurance companies for the cost of doing this program? And she says, well, the only way she can do that is to actually code higher, so a 99214, because of the chronic care illness. Nonetheless, I think for primary care, it really is the right way to do medicine, and I think a lot of practices are trying to do this kind of model.